welcome to the deep dive. Today we're tackling a really significant piece of research. It's focused on a tricky medical problem. Juxtarenal abdominal aortic aneurysms.
Way.
Now, that's quite a mouthful, but essentially we're talking about bulges in the main blood vessel in your belly, the aorta. And the crucial part, these bulges are right next to the arteries feeding your kidneys.
So fixing these is definitely high-stakes plumbing.
It really is. I mean, when you have an aneurysm that close to such vital organs, the approach has to be incredibly precise.
Yeah.
Keeping blood flowing to those kidneys, throughout the entire repair, that's the absolute top priority.
Exactly. And the source that's got our attention today is a report called Results of the United States Multi-Center Prospective Study Evaluating the Zenith Fenestrated Endovascular Graft for Treatment of Juxtarenal Abdominal Aortic Aneurysms.
So proper clinical trial data. Yes, real-world data, not just theory. Our goal today is really to understand what this study found about a specific type of minimally invasive treatment, and what that means for people facing this condition.
And the specific tool we're focusing on here is the Zenith Fenestrated Endovascular Graft. It's made by Cook Medical.
Fenestrated. Sounds technical.
It does, a bit. But think of it like this. It's a custom-made fabric tube supported by a metal framework. That's the stent graft part.
Okay.
And it has these carefully placed little openings or windows. Those are the fenestrations. They're designed to line up perfectly with the arteries branching off to the kidneys and other vital organs, making sure they keep getting blood after the graft reinforces the weakened aorta.
Okay, so let's zoom in on why these juxtarenal AAAs are such a challenge. What is it about that location?
Well, like you said, the aorta is the body's main highway for blood. Just below your diaphragm, it sends off branches, kidneys, intestines down to the legs. When an aneurysm, that bulge, develops right where those kidney arteries split off, well, traditional open surgery gets much riskier.
How so?
Surgeons need to clamp the aorta above and below the bulge to fix it. If that clamping takes too long, you risk starving the kidneys of blood.
Kidney damage.
Exactly. Potential damage. So it's like trying to fix a pipe right where all the other important pipes branch off, not exactly plumbing 101.
That really paints a picture.
Yeah.
So how did this study look at using the Zenith Fenestrated Graft for this? What was the plan?
So the study was what we call a prospective multi-center trial.
Okay, prospective.
Meaning they followed patients forward in time, watching what happened. And multi-center means it was done at multiple hospitals.
How many?
14 centers across the U.S., actually. They enrolled 67 patients, all with these juxtarenal AAAs between 2005 and 2012.
And there were specific requirements.
Yes. A really important one was the aneurysm's neck size. That's the bit of healthy aorta just below the kidney arteries.
The anchor point.
Precisely. It had to be between 4 and 15 millimeters long.
So not a lot of healthy vessel there to work with then.
Exactly right. And for each patient, a Zenith graft was custom designed, using detailed CT scans.
Tailor-made.
Completely. These grafts had between 1 and 3 of those fenestrations, those little openings, depending on the patient's own anatomy and, how many vital arteries needed to be kept open.
And then what? How closely did they follow these people afterwards?
Very closely. For up to 5 years, regular checkups, blood tests, ultrasound to check blood flow, X-rays, and crucially, CT scans to see the graft in the aorta over time.
A lot of monitoring.
Oh, yeah. Follow-up when they left the hospital, then 1 month, 6 months, 12 months, and then every year up to 5 years.
Okay, so let's get to the results. What happened initially in those first few weeks, months?
Well, the technical success rate was remarkably high. 100%.
100%. Wow.
Yeah. They successfully got the graft in place and lined up those fenestrations with the right arteries in every single patient.
That's fantastic. What about immediate complications, mortality?
Very low 30-day mortality, just 1.5%. That was one death reported right after the operation.
Yeah.
And the average hospital stay was quite short, just over 3 days. 3.3 days plus or minus.
Pretty quick turnaround.
And importantly, no aneurysm ruptures, and no one needed to be converted to open surgery during the average follow-up, which is about 37 months.
That sounds really promising right off the bat. What about those all-important visceral arteries? How well did the fenestrations work for them?
So a total of 178 visceral arteries were targeted. The fenestrations came in 3 designs, Small scallops and large.
Okay.
Most for small fenestrations, 118 of them, and they achieved 100% success in getting stents lined up correctly with those.
Perfect for the small ones. What about the scallops and large ones?
The success rates there were lower, 16% for scallops and 11% for large fenestrations.
That's quite a difference. Any idea why?
Well, the study doesn't spell it out in massive detail, but it likely comes down to the technical challenge, right? Lining up larger, more complex openings like scallops and large fenestrations with arteries that might, come off at slightly odd angles or positions.
More variability.
Exactly. The smaller fenestrations probably offered a more direct, predictable path for placing the stents to keep that blood flowing.
And what about the renal arteries specifically, the kidney arteries? Those are the critical ones here.
Right. So out of 129 targeted renal arteries, the study reported a 3% rate of occlusion, complete blockage,
Okay.
and a 9% rate of stenosis, which is a narrowing.
So not perfect, but relatively low numbers.
Relatively low, yes. But what's really noteworthy is that a significant chunk of patients, 22%, actually needed secondary interventions later on.
Secondary interventions, meaning more procedures.
Yes, specifically for issues with their renal arteries, stenosis or occlusion. That was in 11 patients.
22%. So almost 1 in 4 needed something else done for their kidney arteries down the line.
That's right. So while the initial placement was highly successful, it seems keeping those kidney arteries perfectly healthy long-term required more attention for a fair number of patients. That's a crucial point.
Yeah, absolutely. So getting the graft in was a success, but maintaining flow to the kidneys sometimes needed, ongoing effort.
Exactly. Perfect initial technical success, but maintaining that long-term patency, keeping the arteries open, proved an ongoing challenge for some. It required those extra procedures to fix blockages or narrowings.
Now let's look further out, the longer term. What did they find at the 5-year mark?
Okay, so at 5 years, patient survival was good, 91%, give or take 4%.
Pretty high survival.
Yes. And freedom from major adverse events was 79% plus or minus 6%.
Also good. What about the renal arteries long term?
Okay, primary patency, meaning they stayed open without needing any more procedures, was 81% plus or minus 5%.
So about 4 out of 5 stayed open on their own.
Right. But the secondary patency rate, which includes arteries that were successfully reopened with those additional procedures, was much higher, 97% plus or minus 2%.
So if they did have a problem, they could usually fix it successfully.
That seems to be the case. And freedom from significant decline in kidney function was also high, 91% plus or minus 5%.
That's reassuring for kidney health.
It is. However, the freedom from needing any secondary intervention at all was lower. That was 63% plus or minus 9%.
Okay, so let's recap that. Good long-term survival, good kidney function overall. If a renal artery problem popped up, they could generally fix it. But a significant number, maybe over a third, did need some kind of extra procedure eventually.
That's a very fair summary. The long-term data suggests it's durable for survival and kidney function mostly. But yeah, the need for reinterventions, especially on those renal arteries, is definitely a factor you need to consider.
Of course, no study is perfect. What limitations did the researchers themselves mention?
Well, the main ones they highlighted were, first, it wasn't randomized, and there wasn't a surgical control group. Meaning they couldn't directly compare the Zenith graft results to, say, traditional open surgery or even other endovascular methods within this study. They had to look at other studies for comparison.
Got it. Anything else?
Also, because enrollment spanned several years, quite a few patients hadn't actually hit that full 5-year follow-up point when they did the analysis.
So maybe less statistical power for the long-term stuff.
Potentially, yes.
Yeah.
And finally, the strict entry criteria, remember that specific aneurysm neck size. That might mean these results don't necessarily apply to all patients with juxtarenal AAAs, only those who fit the criteria.
Right. Those are important caveats. Okay, let's bring in some expert perspective now. What did the authors and other specialists make of these findings in the bigger picture?
Yeah, the expert commentary really emphasizes how FEVAR, that's fenestrated endovascular aortic repair, has really advanced. It's increasingly becoming a first-line therapy for these complex aneurysms, especially at centers with a lot of experience.
So this study supports that trend.
Absolutely. They point to this study's high technical success, the low early mortality, the good long-term vessel patency. It all supports the idea that the Zenith device is safe and effective. For the right patients, of course. This kind of evidence is really shifting the balance away from open surgery in many cases.
But they also echoed some of those limitations we just talked about, didn't they?
They did. They cautioned that, just because these great results happen at experience centers doesn't mean you'd automatically see the same thing everywhere. Experience matters.
And the re-interventions.
Still a concern. That need for follow-up procedures, even at top centers, especially medium to long term, is something they highlighted as important. They also compared fenestrated grafts to other techniques like parallel grafts or endo anchors, and they felt fenestrated grafts generally offer a better, longer sealing zone on the aorta and better initial exclusion of the aneurysm itself.
Okay, now here's something I found really interesting.
Yeah.
They talked about the type of stents used in the renal arteries.
Yeah.
Yes, that's a really key point. In this study, they mostly used bare metal balloon expandable stents.
Bare metal.
So the experts suggest that using covered stents with a fabric layer might have actually led to lower rates of something called neo-intimal hyperplasia.
Which is?
It's basically the body's healing response, sometimes overreacting inside the stent, causing the artery to narrow again. Scar tissue buildup, essentially.
So covered stents might prevent that narrowing.
That's the theory. It might have reduced the need for some of those repeat procedures on the renal arteries.
So a potential refinement to the technique itself that could improve things even further.
Precisely. They also pointed out that the specific US version of the Zenith device used back then had limitations. Max 3 fenestrations, only 2 could be reinforced.
Meaning it wasn't suitable for everything.
Right. Maybe not ideal for more complex aneurysms involving more arteries or needing the graft to seal higher up the aorta. Things like pararenal, paravisceral, or those extensive thoracoabdominal aneurysms.
So the technology is still evolving to handle even tougher cases.
Exactly. The commentary mentions ongoing studies looking at newer designs, more fenestrations, different sealing zones to tackle those limitations.
And finally, this shift towards endovascular techniques.
Yeah.
It must be impacting traditional open surgery, right?
Oh, definitely. The experts noted a clear decline in open aortic repairs since around the year 2000.
And that raises other issues.
It does. There are concerns about training. Are young vascular surgeons getting enough experience doing complex open aortic surgery anymore?
A valid concern.
Yeah. The commentary suggests we'll likely need to centralize both complex, open, and complex endovascular aortic surgery even more into specialized centers to maintain quality and ensure surgeons get the training they need for both approaches.
So we're seeing a real evolution. Exciting progress, but new challenges too.
That sums it up well. The tech is changing treatment, but it's also making us rethink training and how we organize care.
Okay, so boiling it all down, what's the main takeaway from our deep dive into this Zenith Fenestrated Graft study?
I think the core message is that this study gives strong evidence that the Zenith graft is safe and effective for selected patients with juxtarenal AAAs. But critically, when it's done at experience centers.
High initial success, low early risks, good long-term survival, and kidney function.
Right. But, and it's an important but, a significant number did need more procedures later, especially for the renal arteries. And the device used had limits for the most complex cases.
And the real aha moment here seems to be that this whole field, treating complex aortic aneurysms with minimally invasive methods, it's just constantly moving, evolving.
Absolutely. Technology, techniques, even training methods, they're all being refined continuously. It's a really dynamic area.
So here's a final thought for you, our listener, to mull over. As this endovascular technology keeps getting better and better, how do we strike that crucial balance? How do we maintain top-level expertise in the highly specialized endovascular centers and ensure we still have surgeons skilled in complex open repair for those who need it?
Yeah, what does that mean for training the next generation? How should we structure our healthcare system to provide the best care for everyone with these really challenging aortic conditions?
Definitely a lot to think about. And that's often where the deep dive leaves us with more questions maybe, but a deeper appreciation for just how complex these issues are. Thanks for diving in with us today.